Good morning all. Welcome to module 2 of extraoral radiographic techniques. Next technique is cephalometric radiography. It is a standardized and reproducible form of skull radiography used extensively in orthodontics to assess the relationship of teeth to the jaws and jaws to the rest of the facial skeleton. Indications are to assess initial diagnosis, confirmation of the underlying skeletal and the soft tissue abnormalities, treatment planning, for monitoring treatment progress, that is to assess anchorage requirements and incisor inclination, appraisal of the treatment results 1 or 2 months before the completion of active treatment to ensure that treatment targets have been met and to allow planning of detention. For evaluation of the orthognathic surgery, pre-operative evaluation of the skeleton and soft tissue patterns to assist in treatment planning, post-operative appraisal of the results of surgery and long-term follow-up studies. This is the placement of the cassette and patient positioning. Two types of cephalometric radiography projections are there. First is a true cephalometric lateral skull projection and second is cephalometric posterior-anterior view of the jaws. This is the resultant image. The patient is positioned within the cephalostat with the sagittal plane of the head vertical and parallel to the film and with the Frankfurt plane horizontal. The teeth should generally be in maximum intercuspation. The head is immobilized carefully within the apparatus with the plastic ear rods being inserted gradually into the external auditory meters. The X-ray beam is horizontal and centered on the ear rods. Radiograph shows steep mandibular plane and anterior open wide in patient with rheumatoid arthritis. There is a mucus retention pseudocyst in maxillary sinus, mucus retention pseudocyst in the sphenoid sinus, a frontal sinus osteoma which is appreciable as a well-defined radiopaque mass. There is a calcification of thyroid cartilage, underdeveloped maxilla in a patient with cleft palate, presence of vermeer bones in the occipital region and open fontanelle in patient with cleidocranial dysplasia, lack of development of parietal bones in a patient with cleidocranial dysplasia. Another technique is posterior-anterior cephalometric projection. The film is placed in the front of the patient perpendicular to the mid-sagittal plane and parallel to the coronal plane. The patient is placed so that the acanthometal line forms a 10 degrees angle with the horizontal plane and the Frankfurt plane in perpendicular to the film. The head is immobilized within the apparatus by inserting the plastic ear rods into the external auditory meters. The acanthometal line is perpendicular to the image receptor. The central beam is perpendicular to the image receptor, directed from the posterior to anterior, parallel to the patient's mid-sagittal plane and is centered at the level of bridge of the nose. This is the resultant image. Now coming to radiography of the maxillary sinuses. There are 4 projections. First one is Waters view. Second is standard occipitomental projection, also known as 0-degree occipitomental. Third is modified occipitomental projection, also known as 30-degree occipitomental projection. And fourth one is Bregman-Manton view. Now coming to Waters projection, it is primarily used to demonstrate the maxillary frontal and the ethmoidal sinuses. Thus, sphenoidal sinuses can be seen if the patient is asked to open the mouth. Another structures are orbit, nasal cavity, coronary process and zygomatic arches. They are also seen. Waters in year 1915 specified that tip of the nose should be 0.5 to 1.5 cm away from the cassette. Mahoney in 1930 found that pitous shadows can be correctly placed by adjusting the acanthometal line at 37 degree. This is the resultant image. The image receptor is placed in front of the patient and perpendicular to the mid-sagittal plane. The patient's head is tilted upward so that the acanthometal line forms a 37 degree angle with the film. Central ray beam is perpendicular to the image receptor and centered in the area of maxillary sinuses. The radiograph shows air fluid level in the maxillary sinus. Another radiograph shows opacified maxillary antrum that is suggestive of vascular lesion. Now coming to standard occipital mental projection, 0-degree occipital mental view. This projection shows the facial skeleton and maxillary antrum and avoids superimposition of dense bones of the base of the skull. Indication for these projections are to evaluate maxillary sinus, detecting the falling middle third facial fracture, Leaford 1, 2, and 3, to assess zygomatic complex fracture, assessment of nasoethmoidal complex fracture, orbital blowout fractures, coronary process fractures, investigation of frontal and ethmoidal sinuses, investigation of sphenoidal sinuses. The patient is positioned facing the film with the head tipped back, so the radiographic baseline is at 45 degrees to the film, also known as nose-chin position. This position drops the dense bones of the base of the skull downwards and raises the facial bones so that they can be seen. The central beam is directed horizontally through the occiput. 0-degree occipital mental view shows multiple middle facial fractures, including the nasal complex. Coming to modified occipital mental projection, that is 30-degree occipital mental view. This projection also shows the facial skeleton, but from a different angle from 0-degree occipital mental view, enabling certain bony displacements that can be easily detected. Indication for these projections are: it is useful in detecting the Leaford 1, 2, 3 fracture, coronary process fractures. The patient is in exactly the same position as for the 0-degree occipital mental view, that is the head tipped back, and the radiographic baseline at 45 degrees to the film, the nose-chin position. The X-ray tube is aimed downwards from above the head with the central ray at 30 degrees to the horizontal, centered through the lower orbit of the patient. 30-degree occipital mental view shows multiple middle facial fractures, including the nasal complex. Coming to the fourth projection, that is Bregman-Manton view, it is primarily used to demonstrate the walls of maxillary sinuses and orbits, zygomatic arches and nasal septum. It demonstrates the medial and the lateral deviation of any part of the mandible. The cassette is placed parallel to the floor. The mid-sagittal plane of the patient's head is perpendicular to the film and the floor. Only the chin touches the film. The canthometal line is approximately parallel to the film. Patient's head is extended as far as comfortable. The central beam is directed vertically. It enters at bregma and exits at the menton. Now this is the end of the module second. Thank you.